Good evening, ladies and gentlemen. Welcome to next in the series of NCAR's coronavirus briefings, as we've called them. We've been doing these very often, and I believe at the end of 2020, this is perhaps the most important webinar that we could have hosted. And we are very privileged to have an extremely knowledgeable, wise, and experienced group of commentators who are going to tell us about how we vaccinate 1 billion plus Indians. That's a challenge that is almost unmatched anywhere in the world, given the structure of our society, given the breadth and length of the country and the different cultures and languages and physical environments that will have to be addressed in getting 1 billion people vaccinated and safe. The plan for the day is that we will request our guests first to set out some agenda items for us to think about. And then one by one, I'll request our eminent panelists, and I'll introduce them in a second, to talk to us about what the government is doing, what should be the role of citizens, what should be the role of the private sector, and indeed how we can meet this challenge of vaccinating 1 billion Indians. I have with me a number of eminent people. I just mention them and then introduce them as we go. First off, I'm going to request Hindu Bhushan, who is the CEO of Ayushman Bharat, our national health mission, to lay out some questions for us to think about. He's very much at the forefront of the technology behind the plans to vaccinate all Indians. His application is currently in the field, being field tested in 4 states of India, and we look forward to the questions that he will pose for us. I will then request Ajay Shah, eminent economist, commentator, author of a recent book with Vijay Kelkar about state capacity and the role of the state and of public administration in getting things right in economic policy and its implementation. He is going to take a little more time to go through a presentation discussing what might be approaches we could take in order to successfully vaccinate 1 billion Indians. I'll thereafter call on a very distinguished panel of 4 people, either in government or just outside government, public health, and they will start with Dr. Renu Swarup, Secretary of the Department of Biotechnology, who will tell us about the development stage of vaccines in India and where we are. Thereafter, I'm going to call on Srinath Reddy, Professor Srinath Reddy, President of the Public Health Foundation of India, who will present a public health perspective on these issues. Then call on Keshav Desiraju, former Secretary of Health and Family Welfare, who has vast experience in this area, but now being outside government, he'll give us also an outsider's view. And finally, I'm going to call on Mohammed Suleiman, Additional Chief Secretary in the Directorate of Health Services in Madhya Pradesh, to give us a state perspective on how the states are gearing up. This will then be followed by an international perspective where my good friend Junaid Ahmed, Director of the World Bank for India, will talk about the World Bank's own perspective, but also the broader international perspective and the issues in the distribution of vaccines across the globe amongst the well-to-do countries and the not so well-to-do countries. And finally, Harish Iyer, who is the Senior Advisor for Scientific Programs at the Bill and Melinda Gates Foundation, which is in the forefront of vaccine development globally, a key contributor to the Global Vaccine Alliance and to COVAX, working with WHO to try to distribute vaccines equitably across the countries of the world. So we have a very rich menu ahead of us. I am grateful to all of you for joining. Please use the Q&A box at the bottom of your screen if you wish to pose questions to our eminent panelists. We will try to take up as many as we can, And we'll try to leave time at the end for them to directly address our questions and attendees. So with that, let me, without further ado, call on Dr. Hindu Bhushan to lay out the questions and challenges that he sees from his operational as well as data-driven end. Hindu Bhushan, please.
Thank you very much, Shekhar, and thank you very much for inviting me to this panel. Looking forward to discussions with the very eminent people in this area, in the country, internationally as well. Let me start with something personal. About 3 days ago, my daughter, who's a doctor working in the US, got the first dose of a vaccine, Pfizer vaccine. And as a parent, as a father, I was so relieved that because she has been working with in the hospital, and so the protection she got meant so much to me. And I was just wondering that the same kind of relief we have to give to millions and billions of people in this country, and the kind of support we can provide. But I must say that,
Hindu, before you proceed, I have to tell you that my daughter-in-law is also a physician and also received her first dose of vaccine literally 4 days after FDA approved it.
yeah,
And so I know we're going to talk about logistics and planning, but essentially the FDA approved it and she knew the next day, the day when she was going to get her vaccine. So something is happening correctly around the world where planning has been happening for the last, I don't know, 7 months, 6 months, 8 months. So I want to just
yeah.
echo
So,
what you just said. I felt a great sense of relief because she has a 2-year-old child whom
yeah.
she meets every day, and she also treats COVID patients during the day. So I
Okay,
can understand what you're talking about.
taken 1 minute of my time, so I will have to add that uh, now. So, 9 months ago, if you'd asked me that is my daughter going to get this vaccine in December, I would say you're dreaming, because we've seen that vaccines take years, if not a decade, to come out. There's some health conditions, HIV/AIDS or malaria, for which several decades have gone by, but we don't have vaccine. And people saying that you'll have vaccine in 9 months' time was looking like a pipe dream. Similarly, other thing that has happened, which is so remarkable, is what you mentioned, Shekhar, this international cooperation. We've never seen this kind of cooperation, that we have this solidarity trials, that we know now much more about what works, what doesn't work in terms of treatment. 30 countries coming together with 500 hospitals. I think that has also been remarkable. And you refer to the COVAX alliance, that countries have gotten together, and 170 countries, ensuring that about at least 20% of the population will receive vaccines. That's also unheard of. I think that happening for the first time in the history of international cooperation at this scale. About 20 years ago, I'm showing my age here, I'd done a research, Asian Vaccination Initiative, and I'd come out with this report. It's called Vaccine Financing in Developing Countries, Trends and Issues. And that shows that was done with the person, very good professional from the World Bank, Amy Batson. And what we'd seen in that report was that, in general, when the vaccine comes and it's available in developed countries, it takes about 5 to 7 years before it starts rolling out in developing countries. So the gap between when the vaccine is available uh, in the world and when it comes to a developing country is about 5 to 7 years. Here, we are seeing that vaccine is available almost simultaneously. A few weeks here or there, or a few days here and there. Actually, India already has the access, in the sense that they are evaluating the right now. It's with the regulator, so it's potentially available to India. So, and which is almost the same time as when FDA actually got to look at it. So in that sense, I think it's a great thing to do. Similarly, what UK did about 1 week ago, that they announced very clearly, without hiding, that there's a new variant, and they knew that once they announce it, there'll be economic impact of that. People are going to be stopping their flights and trade, and hundreds of trucks, thousands of trucks going to France and other places will be stopped. But they did it because they didn't want to hide it. And that kind of international cooperation, that uh, feeling of sharing, and this is a global thing, and we, even if it is going to be impacting us negatively, we are going to be sharing information. I think it's really very heartening, and I think that is the way to go. Now, coming to the vaccines in India, you're right that we are all set to go. There's a huge plan. I shared that by email to you, with you as well. I don't know if you saw that, but as a not as a government officer or government staff, but as a professional or as a person who's curious about both public health and economics, I want to pose 5 questions. And some of these questions are rhetorical and maybe answers are right there, but still I want to provoke some of you that in terms of should we be taking them on their face value. First question is, should the government be financing it? You know, of course, there's a communicable disease. Yesterday we were discussing about it. There are negative externalities. So there is a need for supporting this. There has to be some subsidy involved. So government should be financing it in some ways. But we have seasonal flu every year, and that kills a lot of people. Maybe not so much as corona or COVID has killed, but we don't provide a vaccine for that. For last 20 years, I've been taking it every year. Earlier, my employer, ADB, was supporting it. For last 2 years, I've been paying it for myself, for my family, and it's a private good, and I'm happy to take that. So for COVID, uh, since it's highly infectious, it's affecting large number of people. It is leading to a lot of deaths. Is there a uh, is there a rationale for government financing it? But at what point? Now, if R naught, which is more than one, and if it's two, and it's very highly infectious, one person, if you vaccinate one person, you are saving two others. It makes sense. But now, at this stage in India, when our figures show that R naught has come down below one in all states, and it is going down further, is there a, and if R naught is less than one, and I think so some of you would bear me out, then this epidemic is in India is self-limiting in that sense. So if it is self-limiting, then should we be financing it? And is there any threshold value? If it's not 1, 0.9, 0.8, 0.5, where does this R naught should be when it becomes not necessary for public finances to go? So that was the first question, that should the government be financing it and at what level? Second question is, who should be covered? Because there are three type of people that one can think of. One is people who are more likely to be infected. Second is people who are most likely to be impacted. If they get the infection, they will have much worse outcomes and probably death. Or people who are most likely to spread it. And from the public health perspective, the third category, people who are more likely to spread, should be looked at, because probably they are the people who, if you focus on them, then the you can stop the spread of the virus. But also at the same time, how do we deal with those people who are willing and able to pay for it? So how should we have a differentiated strategy where we've identified a group, and right now we are focusing on the first two groups, and I think I fully support that. People who are more likely to get infected, which are the frontline workers who are coming in contact with virus on a daily basis, and people who are more likely to be impacted, those people who are elderly, have comorbidities, and they would have higher chances of getting sick or sicker, or mortality is much higher among them. So we are covering those through the government resources. But how about those people who are coming in contact with large number of people, like say taxi drivers, because they are taking people every day hundreds of people. So they are the people also who are going to likely to spread a lot of virus. So shouldn't we be focusing on these people who are likely to spread virus much more? And the question about how do we look at those people who are willing and able to pay and not cover them. So that was my second question. And the third question was that what is the connection between vaccination program and prevalence of prevalence of the virus, or seroprevalence, or people who have been infected, and what at what level we think that so-called herd immunity has been reached. And been having some good exchange this morning about various studies which are out there. But whatever you look at, there are some problems. First, all of these studies are about 4 months old. And if we take the one study which Dr. Reddy sent, which says there were 12% active cases at that time in Karnataka. And 12% is a huge number. Right now, if you look at the entire number that we have confirmed cases in Karnataka, is 1.2%. So 10 times of the entire prevalence of Karnataka so far, 12% were actually active cases about 4 months ago. And if at that time R was 1, then probably those 12% cases would have infected, or about 36%. If you just take 2 cycles, 36% more. So we are looking at probably 60, 70, 80% prevalence of virus, or prevalence of people who have already been infected. So if we've reached that level of 70, 80%, at least in many neighborhoods and many cases, is that should vaccination go on even then? So, or what is the level of seroprevalence that we should be aiming at when at that point vaccination doesn't make sense? And among in seroprevalence, what is happening is also the timely survey and timely reports and sharing of data. Probably we need to do much more of that. But also one open question is that in seroprevalence also, there is a possibility that we are undercounting the numbers, because not everyone who gets infection develops antibodies, and those who do develop antibodies after some time, they come down. Sample size of 1, I was confirmed positive, and about 1 month later, I did my antibody test, and I was negative. I wanted to be positive for the first time, but it was negative. I did it again. I was negative, and I've heard of many people from the government who were infected, who were confirmed positive through RT-PCR, and then they didn't have antibodies. So even seroprevalence probably are undercounting the prevalence of this disease. Are there some numbers which show that how should we impute the actual prevalence based on the seroprevalence surveys? Is it 10 percentage point more, 15 percentage point more, or that kind of thing has to be seen? And the question is that at what level we think that vaccination spending $7,000 or 7,000 crores is not really worth it. My fourth question is that it's really interesting, if you look at the whole picture of India right now, and there are mathematical models to show that for vaccination to be effective, it has to be done comprehensively in all states, and it has to be equitably done. This modeling has been done at the international level, showing that if all countries get vaccines proportional to their population, impact will be much more as compared to if only some countries get it, because of course, because of the mobility of people, but also the herd immunity has to be done at the international level, or in this case, um, at the national level, at the country level. But if you look at the huge variance that we have across states, and today I'd ask my colleague to do some simple analysis in terms of correlation between the strength of public health system and prevalence of COVID. So Niti Aayog has done this indexing, and they have ranked the states in terms of how strong the systems are. And guess what? Number one on the state in that list is Kerala, and Kerala model, of course, and Kerala is number one on that list, and they're also highest in terms of COVID per million population, highest by far. Number two is Andhra Pradesh, or number two is Maharashtra, and guess what? On COVID rank, Maharashtra is also number two. Number three is Andhra Pradesh. And guess what? On COVID test, number three is Andhra Pradesh. Four bottom states in terms of ranking are UP, Bihar, MP, and Rajasthan. And all those four, guess what, are at the bottom in terms of COVID per million population. And I realized for the first time today that at the national level, our good population actually is being driven by those poor performing states in the health sector. So there's something going on that we need to understand. Is it that those states are not testing enough, not reporting enough? Because Bihar, Bihar has gone through this massive election. They had Chhat, they had Diwali, and still their numbers are very the lowest in the country. They have the worst healthcare system according to Niti Aayog, and still they are doing the best in terms of all indicators on COVID. So now, if that is the case, and if one hypothesis is that their systems are not as strong, and that's why they're not being able to detect or identify people with COVID, then that doesn't give us confidence that they'll also do well on vaccination. If they don't do well on vaccination, again, the effectiveness of vaccination at the country level will be much poorer. So how do we ensure that these lagging states also have a strong vaccination program? As so, if Kerala does well, Tamil Nadu does well, Andhra does well, or Maharashtra does well, that will not be helpful unless all these states also do well, because otherwise, because of the population movement, the impact of vaccination will not be that much. So how do we ensure that it's more equitably done? My final question was that about the mutation of virus. And as we know that there are new variants of virus coming, and we know for flu, we have new vaccine coming up every year. And it is much more likely that this virus will keep mutating. And we have one variant right now, and we are told that the current vaccine will support it. But this is not the end. The further mutation will take place. If mutation takes place, do we have systems, and how do we have systems to ensure that our vaccines cover it? And at some point, mutation will go to a point when new vaccine will be needed. And so when that comes, a new vaccine comes, then are we going to be again vaccinating the whole country with a new vaccine? And are we going to be repeating it every year? So it's not a one-time thing. Like, so we have to decide this policy now that we are doing it for this variant of COVID. But are we going to be doing it every year based on this, or are we going to be making it available and people can use it? So that's the final question that I have. And with that, probably I've taken my time and give you back to Shekhar.
Thank you, Indu. And the last question, of course, also extends to the permanence of the first vaccine in itself. It may not, it may not be 20 years. It may only give you 6 months immunity, or we just don't know enough about it as yet. All these questions are really terrific. I know that they're going to motivate the discussion. Let me go straight to Ajay Shah, but also recognize that Professor Kang has joined us. She hopefully will come in at some point, perhaps even answer some of the questions that you have raised. But Ajay, let's have you share your screen with us and take us through your thinking about the public economic side of it, and how, from what we know, how things can actually be done well in terms of service delivery. How can we apply that to this challenge that our country faces now? Ajay?
Thanks, Shekhar. Let me get started. 2020 has been the year of thinking about COVID-19. In January, we were hearing about it. In February, we were worrying about it. In early March, we were writing policy papers. By late March, we had lockdowns, and it remains a very big problem for all of us. What has been achieved in 2020 in terms of the financing, the contracting, and the science on vaccines is just miraculous. It is amazing how far we have come in the global health community in terms of being able to deliver achievement by the end of the year. Now we're standing at the end of 2020, and we should think about the costs and benefits of various paths and look for incentive compatible solutions. I thought Hindu Bhushan's introductory remarks were absolutely bang on. That is precisely the list of questions that we should be applying ourselves to. And on some of them, I have some things in this show. Let's start by thinking about the problems of a population scale, government led rollout. For many of us, we started thinking about this when Nandan Nilekani wrote two articles in the Hindustan Times. And roughly speaking, he was dreaming that could you build a new organizational structure, use IT systems, use Aadhaar identification to be able to uh, make every single individual legible and do the management to get 28 days across two doses, push leadership and control in the government in the direction of what was done in the startup phase of UID AI. And Government of India has built a big rollout plan, and elements of this are in motion. We're also seeing what's happening in other countries. I was struck by the simplicity and elegance of what is going on in the United States. Basically, buy in wholesale quantities from producers, get UPS and FedEx to ship it to CVS and Walgreen, who roll it out to the population. It's a nice, simple system. It's one contract with producers, one contract with UPS, FedEx, one contract with CVS, Walgreen, and it starts making you think about how to design these things. When we think about the questions we face on SARS-CoV-2 in India, the most important role model that we should look back at is the smallpox story. Smallpox was a remarkable population scale success story. And yet, there are many interesting differences between what happened in smallpox versus what we see here. From 1971 onwards, there was no need of a cold chain for the smallpox vaccine. Then look at the timescales involved. Uh, from 1970 to 1973, they got it down to a few states. And then the last push was a special mobilization, which was 73 to 75. In that period, government caseworkers were meeting 330,000 households per day, searching for new cases. Smallpox was easy. You only had to look at the face of a person and make sure it was not chickenpox. There was no complicated testing. There was an external dimension. The whole world was fighting to eradicate smallpox. The WHO was very conscious of the importance of India. I believe about 50 advisors from the WHO worked in the Indian smallpox project. And you have to locate it in the context of that state capacity. We were still in the early years after independence with the idealism and the passion and the civil service capabilities of that age. In the later years, there were big projects in Indian public health on malaria and on polio, which did not work as well. So trying to transplant some of the smallpox story here is not quite easy. Let's think about the state capacity constraints.
Ajay,
Bluntly,
Ajay, I just want to intervene for 1 second.
yes.
I know that Dr. Renu Swarup has to leave by 7.
Okay.
So at some point, I may interrupt you and request her to come in so
Yeah.
that we get to hear from her. It's very important to
Yeah.
hear about the development story of vaccines. So if, with your permission, I may interrupt your flow
Sure.
somewhere in between. I apologize for that, but thank you.
Yeah. Now, bluntly, if you want to get two doses and a cold chain to 1.3 billion people, it has never been done in India. Okay, it has never been done anywhere in the world. If you look at the vaccines situation in India today, there are probably 25 or 30 million infants who have to be vaccinated per year, and we do a reasonably poor job of that. So if you think of a state capacity that reaches about 30 million people, and you really become optimistic, you would think maybe we can reach 60 million people. You could reach 120 million people. It's very difficult to go much bigger than that. Just basic management common sense. It's also important to emphasize the role of decentralization. Conditions in Bombay or Kerala are very different from UP or Bihar, as Hindu Bhushan was saying a moment ago. Most of health is in the state list of the constitution, so there is a very limited role for the union government in health in any case. A bulk of the operational capability of the government is in state and city governments. Who actually does infants in India is the city government and the state government. And if you turn to the overall supply of healthcare workers and management capacity in healthcare in India today, it is largely in the private sector. So to think of a union government story in this is a bit of a stretch because the capability is really not there. What would go wrong if we tried to design a state heavy system? One problem is that there is not a lot of cold chain with the government system in urban India. The next concern is that if we put a mission mode focus on COVID-19, will it adversely impact on other regular immunization work? Then a lot of the last mile healthcare workers are largely in the private healthcare sector. Then if you think of precisely 28 days apart for the two doses, it requires a different level of process maturity. Even asking private people to do it would be pretty hard. And there's very little in place in India with adult vaccination in India. So we'd have to really figure out what's our long run strategy for adult vaccination. And ideally, the COVID-19 work should feed towards that. I want to emphasize the problem of duds. So suppose a box of milk is moving at 4 degrees from farm to fork. And if it reaches your house and the milk has been mishandled, then some of the customers will notice the milk is spoiled, and that will generate some feedback through the market economy. But with drugs and with vaccines, the customer has no way of knowing that you got a dud, particularly if there are stringent tolerance limits in terms of the cold chain that is required for vaccines. Consumers will never know that they got a dud, and it's going to be very difficult to generate confidence on the part of consumers that actually this is being given to me through a system that I can trust. There are two kinds of hesitancy in the population that we should recognize, and they have interesting implications for how we think about policy design. The first is vaccine hesitancy. For every single one of us, we need to know three numbers, three probabilities, P1, P2, and P3. If I get the vaccine, what is my probability of getting sick over a given time horizon of interest? And what is my probability of running into side effects? If I don't take the vaccine, what is my probability of getting sick? These three numbers, frankly, are not known enough. And there is a lack of scientific knowledge. So you're really living in a WhatsApp world where all kinds of nonsense is going around on the internet. So many people are going to make up their mind that, this is not really efficient for me, and I don't want this, I don't need this. Already there are WhatsApp rumors of all kinds of nonsense about the side effects of the existing vaccines. In parallel to this, there is the problem of information hesitancy. There is an increasing pushback by the people of India against the state amassing information about the citizenry. So, we are all going to be in a world where we will be exchanging notes with each other about which health testing facility is giving us the service of our lab tests without feeding information into some IT system. And if we push a lot on state coercion on the vaccine, we will just get back a lot of unhappiness from the populace. Now let's turn to the herd immunity discussion as Hindu Bhushan began talking about it. There are two very different visions of immunization. To people in the field of public health, the subject under analysis is the population, never the individual. Public health is the study of the population, not the study of the individual. So the game is how to get R naught to low values. Sorry, it should be less than 1. How to get R naught to less than 1 so that every now and then there'll be some cases, but basically the dynamics is working in your favor and the epidemic is working out. That, for example, is the intuition about why the effectiveness of a vaccine that is required for US FDA approval is only 50%, because the point is you want to tip the system over into herd immunity. As an example, the smallpox campaign in India basically aimed at getting 80% coverage, which is enough for herd immunity, and then putting out individual fires, but not immunizing the entire population. So that's one vision where we're going after the population and we want to get enough people immune so that the fires start burning out. There is another very different vision of the vaccine as a private good, where I want to get the vaccine, I want to pay for it because I benefit. That's a different problem. And we need to constantly manage this in our heads, that there is me as a consumer and there is we in the field of public policy. And we need to bring public health foremost in thinking about public policy while recognizing that there is a private market. There will be private buyers. There will be people who will import vaccines, roll them out, blah, blah, blah. That's going to happen in parallel. Now, India is well on the way to herd immunity in terms of what is going on with COVID-19. As Hindu Bhushan emphasized, the conventional data about tests or deaths has many limitations. It's much more useful to look at seroprevalence, and ideally, this should be research that is done using formal statistical sampling. Here are some recent papers which are data points. There is one paper which is good, thorough statistical sampling in Karnataka, and their result is that there was 50% seroprevalence. If you take the mean value of the dates, it's 21st of July. So on about 21st of July, seroprevalence in Karnataka was about 50%, according to this paper. There is another paper which has worked on Bombay slums in early October and found about 75%. There is another paper that worked on Nagpur in November and it found about 50%. As was emphasized, the mapping from antibodies to immunity is complex. There are elements of the innate immune system at work. Sometimes the magnitude of antibodies subsides over the months after infection. And sometimes people show antibodies and yet do not have immunity later on. So I recognize that this is not one-to-one, and we need to keep that in the back of our mind. Now, all these papers were 5 months ago, 2.5 months ago, 1 month ago. So the spread of the disease would be going strong. Professor Reddy sent us a paper where there was a lower value for Karnataka of about 27% on seroprevalence in the month of September, but there was an astonishingly high value for the number of people presently infected, about 12%. So if about 12% of Karnataka was infected in September, then basically by November, December, it's gone to 100% of the population because this thing is pretty infectious. The numbers on seroprevalence are a means to an end. The ultimate point is, does the disease start dying out? And certainly in some parts of the country, the disease has started dying out. As an example, in the slum of Dharavi, for the first time since 1st April, on the 25th of December, there were 0 new cases. And on the 26th of December, there were 0 new cases in the suburb of Dadar as well. These are very large populations by world standards, where you're doing a large amount of testing and there's not even one RT-PCR positive in the recent days. Similarly, Bombay has started closing down some COVID-19 treatment facilities because they were just sitting around for months not being used. So I think there is a lot of evidence that herd immunity is developing, the epidemic curve is shifting to the late stages, and the disease has started dying down. And we're talking about evidence from late 2020. In any case, the vaccine rollout is further out in the future. By that time, the disease will have made even more progress. Now let's turn to thinking about what would happen in the private market for vaccines. The slide shows the bulk price being paid by governments for 6 different vendors of the vaccines in the world today. And this is in dollars and euro. And I will explain in a moment why I'm taking interest in the number 500 rupees per dose, which happens to be €6 or $7. At present, the AstraZeneca vaccine is in that range. The Johnson & Johnson is a bit beyond. The Sanofi is a bit beyond. And I'm going to come back to this in a moment. Now, what's going to happen in the economics of this vaccine industry? Basically, the supply is going to explode because just like 2020 was a triumph of the science of developing new vaccines, 2021 is going to be the triumph of manufacturing as these things will get up to scale. The cost function will shift, the supply function will shift, right? Similarly, the demand curve is going to shift. As herd immunity sets in, the subjective threat perception of customers will go down. All over the world, there will be a decline in the willingness to pay, and the demand curve will shift left. So this simple economics suggests that we're going to get a price collapse. So we're going to get lower prices, and many of the vendors will be producing at prices of rupees 500 or below. Putting all this together, what can we think about the way forward? If you think about a union government led population program, my sense is it's difficult to do. Okay, we're not doing well on 30 million infants in India today, which is done by lots of states. The union government doesn't have the machinery. So thinking about 60 million is difficult. Thinking about 120 million is very difficult. 1.3 billion is inconceivable. And the gains are relatively small because a good chunk of India would already have achieved herd immunity within January, within February, by the time we'd be ready with any kind of state system. The intuition from Bombay is that in the slums, you're pretty much done. The buildings, you have not. But in the buildings, there is a willingness to pay. Private people would pay 2,000 rupees per person to a private vendor to get the vaccination done. Now, where am I plucking the number 2,000? I'm using the value of rupees 500 per dose. So that's 1,000 rupees. And I'm putting in 1,000 rupees for the last mile expenses. So it's adding up to 2,000 rupees per person, which would be what private people will charge to import some vaccine and deliver it to a private customer. So in the buildings, people are going to be doing it themselves. What are some design principles that we should bring to it? It's good to have distributed energy. Let's have many, many managers. Let's have many, many management teams. Let's have lots of energy from various people going all around the landscape trying to get more immunization done. The more energy we can bring to this, the better. Let's be diversified. Let's not bet on any one silver bullet. India is a complicated country. There's many a slip between cup and lip. Many initiatives should be in flight because you never know which one is going to work well and which one is going to fizzle. Let's have more local control. Okay, there are phenomenal organizations all over the country, in health, not in health, who can all supply management and leadership, and they're much more accountable to their local communities. They will do better as compared to any centrally planned thing. Let's get more inputs, let's get more capabilities, let's get more money wherever it can be found. So if you just do simple arithmetic, 2,000 rupees per person is 2.7 lakh crore rupees for the whole population. It's a lot of money. The Indian exchequer would find it difficult, not impossible, would find it difficult to find this money. Whereas a lot of private people are willing to pay rupees 2,000 per person. Let's harness as much resourcing as we can. And finally, let's focus and worry about state legibility. Let's respect information hesitancy. Let's reduce the amount of information about individuals that is going to the government. And particularly because you've got two doses 28 days apart. Let's be very careful about what information is stored where. If information goes into a physical ledger, it's generally safer than information that goes into a computer system. If information goes to a private firm, that's generally safer than information that goes into a government system. So with all this, can we think of...
Ajay, can
Yeah.
I just request you to pause? I'm sorry, but I do want us to hear
Mr.
from
Shah,
him.
Mr. Shah, don't disturb Ajay. Let him finish. He's nearly to the end of his presentation. I'll move it 5 minutes ahead. Don't disturb him. He'll break his thoughts. Please don't do that.
Thank you, Renu.
Thanks. I'm almost done. So I would like to propose some things that we should actually do. The first element is we need better data. Okay, every city, every state should create public goods of panel measurement of seroprevalence, which should be linked to household characteristics. This is just incredibly important. It's an embarrassment how little evidence we have today to think about these grand questions. We should be releasing this micro data. We should be researchers will produce web systems to guide individuals about what are the risks that you face. So this needs state money for these studies and state contracting to get more and more organizations to produce this kind of data. I believe the city of Nagpur, the city of Pune is starting on this kind of work. Element 2, can we have a lot of transparency by private healthcare providers? Here really I'm worried about that there are severe cold chain requirements, and we would worry about the extent to which some customer is getting a dud. So we should use state coercion, we should use state power to force private companies to tell us a lot about what they're doing. So Apollo hospitals should sell a service where they are offering the customer a COVID-19 vaccination, but state power should force Apollo hospitals to release every detail about their process design, about how this is being done, so that we can assess the extent to which the purity is actually maintained. Could we use a little more government power and government money in this system? For example, there will be private vendors importing vaccines from Moderna. Could we have the government of India paying Moderna to run a system in India where they do mystery shopping at the street level and report on the state of purity of Moderna vaccines as seen at an Apollo hospital's front end all over the country? And state funding should be given to academic researchers to study all these offerings and guide consumers about which provider is doing well and which provider is doing badly. Element 3, it would be great if employers would really take care of their own employees. So, I would request Shekhar Shah that NCIR should be figuring out its employees, the family members of its employees. Can we find a contract with a private healthcare vendor who will import the vaccine or buy it from Serum Institute and deliver it to all the employees? Okay, so similarly, think of the Secretary, Department of Economic Affairs, think of the Joint Secretary Admin of the Department of Economic Affairs. They should organize vaccination for all the employees and the family members of the DEA. There are about 30 million civil servants in India. With family members, that's about 120 million. That's a lot. That is 4x the number of infants where the state system currently struggles. So if the leadership of every single government organization will organize for its own employees, where there would be direct accountability in the eyes of its own employees, that would be pretty good, and it would cover 120 million people. It is incentive compatible for employers to build these systems for their own employees. And you don't need any state coercion here. You just need encouragement and state funding for its own employees, for the 120 million family members of civil servants. Element 4 can be vouchers. So suppose there are public health authorities in one city like Pondicherry who see a low-income community where there is low seroprevalence, and so the gains from a vaccine would be large. Or suppose there is an unusually important category like school teachers, where there are unusually large gains from vaccination. So MOH has been articulating some very important priorities, such as healthcare workers and the elderly. You could use public money and give vaccine vouchers. So once again, the organization, the management, the energy of the private healthcare industry can be used for the last mile delivery. So in short, I'm thinking that we should have a portfolio of initiatives. We should try many things. We should have local control. And the game is to get R naught less than 1 in each geography of India, and then the epidemic will die out. Thank you.
Thank you, Ajay. As usual, you've really dived deep into basic economic principles, principal agent problems, as well as a tremendous understanding of state capacity. I won't comment more, but I think you've laid out a fantastic agenda for us. Your presentation will be available on NCR's website, and I would urge everybody to take a very careful look. Let me turn now quickly to Renu Swarup, Secretary Biotechnology, to give her understanding and insights at the early stages of this whole supply chain, the development of the vaccines. Renuji.
Thank you very much, Mr. Shah. And I think this is a very interesting discussion, very well laid out so far. And as has been pointed out by the earlier speakers, the development of vaccines is key and critical to this whole debate on and discussion on how would vaccines be delivered to this 1 billion population that we have. I think the point that was made is that today in India, we are at a situation where we are talking about our indigenous vaccines being ready, rightly said by Hindu Bhushan, probably around the same time that we have vaccines being cleared at the FDA for use by other nations across the world. It's important to understand what really went into this vaccine development for COVID. How is it that we've been able to look at a vaccine to come in about less than 12 months? How did India suddenly get so well prepared to have a vaccine at the same time as other countries globally? And I think it's important then to see what the COVID did to us. So COVID brought us a huge challenge in terms of all the various challenges that we are seeing. But I think clearly what it did was to bring in the opportunities for science and technology. And what was also very interesting is that the scientists, the technologists, all came forward to seize this opportunity and to deliver what they really had been tasked with, and that is bringing out solutions, S&T solutions to fight this COVID. It's also important then to reflect on two aspects: that how did we do it so very quickly? I think it's important to recognize the investments which have gone in to create a very strong foundation. And we then use that foundation to scale up very well. It's also important to point out here that never before have we seen this level of collaboration, this level of partnership between different stakeholders. The academia and industry definitely, international collaborations, and all the concerned agencies who play a major role in taking this entire development to deployment or taking it through the translational chain. We've had excellent success earlier in terms of other vaccines that we've developed, in terms of our entire pharma sector, how we've responded to it. But in this, we also have, again, a very unique opportunity where we are not talking about just one vaccine. We're talking about a basket of vaccines. We're talking about different platforms which are coming out. And I think that is an interesting opportunity, but it also brings in the complexity of seeing how we move forward. And the complexity which is going to be in the program implementation for the immunization was a key factor that was kept in mind when these vaccines are being developed. So they all must fit in with what really is our available range of program implementation, considering what our logistic supply chains are, where are we positioned. If you see all the Indian vaccines which are being developed, they are actually keeping that in mind, and they are sort of meeting the requirements and the criteria that are for this immunization program. Many times, and through this vaccine development stage and the various agencies which are involved in it, and my own department primarily, which has been the key department steering this vaccine development initiative, one question that gets asked is, how do you do it, and how did you do it in 12 months? How did you do it in such a short period? Which were the steps that you compromised on to be able to achieve this? So there is one clear response that we have to each one, that there has been no compromise on any step that's required to ensure the safety, the efficacy, the immunogenicity response that this vaccine will bring in. Safety is of primary concern for every scientist when they take up any development stage. And this is, of course, a vaccine for human health. So how did we then do it? I mean, that's obviously a question everyone would naturally ask, that what was that miracle that you did to bring it down to 12 months? So I think there were 2 or 3 key factors, and one I've already spoken about, and that's the collaboration that made it possible. I think this collaboration is very important because each one built upon what the other was offering. So I think it was complementary strengths that came together. And this is a clear example of what excellent teamwork and complementary strengths can do, not just to deliver quality, but to compress the timeframes. As I said, there was existing infrastructure, existing expertise that we built on. Most of the vaccines which have been built, have been come out today, are on existing platforms. So they use that knowledge which was there to be able to then build and bring out new vaccine candidates. And I think that is really what helped us to reach where we are today. You look at the regulatory response, which was again very key and important at each step of the vaccine development, whether it was the preclinical studies or the clinical studies, the data requirements. And India is, in fact, as a country, the government, the agencies involved responded very, very quickly to this. And in fact, the first set of discussions we had on the vaccine development, the S&T solutions that we would have was in January itself. Just when we did realize that it had not even been announced as a pandemic at that time, but we did realize the severity of this whole thing. And we took this decision on. We created a rapid response regulatory framework as early as February. We started putting out guidance notes on what really would be required by the manufacturers for vaccine development. And those guidance notes have been there right through. We now also have a guidance document for the COVID vaccine, which is the draft guidance document which CDSO has put out. So all this facilitated the stage for the vaccine development. We have, as I said, 5 or 6 different platforms that we are currently working on within the country. We have novel platforms as well. We have the mRNA vaccine, we have the DNA vaccine. The DNA vaccine, of course, has moved forward and it's already in the human clinical trial stage. They are now with the regulator waiting to getting their data examined for phase 3. But it's very interesting to note that across academic institutes, across industry, we have more than 30 vaccine candidates which our scientists and researchers took forward. So different candidates, different platforms, but obviously it's a basket, as I said, and then they go through many, many filters. And today we have nearly 6 of them which are in the clinical trial stage or in late stages of preclinical to move into clinical trial stages. And the others are also moving in as we speak. There is so much of research, so much of support that's going on. So what really is the support that we've given for these candidates? And we all know the candidates which are in the clinical trials. It's all been covered all over by the media. So I don't need to speak about which those are. But yes, we know it's the AstraZeneca serum candidate, the Bharat Biotech candidate, the Zydus Cadila. We have biological E. We also have Genova, which is the mRNA, which has now got clearance to get into human trials, the indigenous mRNA. And that hopefully, as the current data shows, should be within the 2 to 8 degrees. So having an mRNA vaccine, which is going to be within 2 to 8 degrees, would probably be something we'll all be very happy and excited about. But let's see how the data moves ahead. We then have other platforms and candidates which are being developed by these very companies. Bharat has another 2, Serum is also looking at 2. So that's the whole basket of it. But it's also important that what really is the support that the government gave to facilitate this vaccine development. Naturally, everybody would feel it's a financial support that was given. Yes, there was financial support given as seed fund, as other funds to facilitate it. And that's very important because it helps you to technically do a due diligence. But I think what was more important is the mentor network, the expert network that got created to provide the scientific guidance to take this forward. And I think that has really helped to facilitate that. Our own national experts, our international experts, our collaborations that we already have with the US, Indo-US Vaccine Action Program, more than 30 years in existence, that collaboration. We then have the CEPI. We have an INCEPI program that we had set up 3 years back, trying to look at vaccines for epidemics. Never ever thought that we would make vaccines for pandemics. We had a disease X there, not knowing that this is what the disease X is going to be. We then have our collaborations with the Bill and Melinda Gates Foundation. We have our collaborations with the World Bank. In fact, the World Bank and the Government of India, 3 years back, set up the first time a mission program called the National Biopharma Mission. That actually set a very strong foundation. And Mr. Junaid is here. He knows the number of discussions we had. Never before had an R&D program got a World Bank loan to set up whole mission. What we wanted to do was create an ecosystem for innovation, create a structure so that we could help the startups or the academic research to very quickly take their research through this ecosystem to deliver a product. I don't think we ever imagined that during the midterm review of this World Bank mission, we would actually be delivering solutions for COVID. But you see how investments have worked. Foresight has worked. We've been able to create this very strong ecosystem. So we've facilitated these, and we are continuously facilitating these vaccines to move in. So there has been a question as to which vaccine. Is it going to be annual? Is it going to be 6 monthly? Is the mutation going to help? Are we going to look at chain vaccine? I think we'll still have to wait for data to come in for that. I don't think we have sufficient data to give an immediate response to it, that what is it that we're going to have. But yes, the scientists are at work on it. And I think we will keep getting data continuously to see what is it going to be. The ecosystem that we have created is a wonderful ecosystem, which now all these vaccine manufacturers are using. We've got a centralized network of immunogenicity labs which have been set up, so that, and the laboratory, the Translational Health Sciences Institute at Faridabad is actually recognized by CEPI. We have another 5 such laboratories that we are setting up. We've set up clinical trial sites. Today we have 11 sites which have been set up. We have another about 30 of them which are in hospital settings. So creating these sites, creating these well-developed sites facilitates the vaccine developers. You're talking about 6, 7, 8 vaccines getting into clinical trials. How are we going to do these clinical trials till we do not facilitate this? And that is really the planning. So you spoke about the planning, advanced planning for the immunization program. There has gone a lot of advanced planning to even be ready for a clinical trial for a vaccine. So this is, I think, as a complete advanced planning that we've done in that. And today we stand where we are. As I said, we've got these vaccines which we are hoping we'll be able to scale up. The government announced the COVID Suraksha mission in the third package of the Atmanirbhar Bharat. So we got a 900 crores, $125 million to accelerate at least 6 vaccines into the towards market. And yesterday we had the first meeting of our decision committee. And I was pleasantly surprised to hear from my team that we're probably going to have more than 6 candidates that will need this sort of a support. So you see, it's something that we need to feel proud of, but we also feel very confident that as we move on, there is going to be this continuous supply of vaccines which will come in. Some of them are with the regulator right now for approvals. We are hoping their data would be good and they would be able to get clearances there. But they're going through a very rigorous scientific review. So we are confident that their data, as they move on, would be full for the regulator to clear on. So I would just like to conclude by saying that it's not just the support for the vaccine development in terms of financial support, it's the network, it's the ecosystem. And India today, which was always known to be a vaccine manufacturing country, it's not today that we've developed a vaccine for COVID and we can sort of take pride in that. India has been recognized as a vaccine manufacturing hub, new vaccines being developed. And I think that really is coming out. And as has been said, it's not just vaccines for India, it's vaccines for the world that we are looking at. And many of our vaccine manufacturers are now looking at becoming a part of COVAX, supplying to COVAX, the Indian neighboring countries we are having discussions with. We're also building capacities in the neighboring countries, helping them to take on capacities to be able to take on trials or build capacities for other than vaccines. So I'll just conclude here by saying we are well positioned, but I will respond in a minute to what Hindu Bhushan raised about the mutant variant that has come in. And I think that again is being addressed. We've already, if you've been hearing all the news items which have come in, we've launched the Indian SARS-CoV genome sequencing consortia. 10 laboratories have been identified. We've put this whole structure in place. They've already started. And moving forward, there will be a continuous sequencing done. As we have done sequencing, we've done about 4,000 to 5,000 sequences, may not be sufficient, but recognizing the fact that yes, there would be mutants coming in, maybe the UK variant, we may have others that we may have to look at. So this is in fact already rolled off this consortium, and they're going to start maybe in a day or two looking at future positive samples to take on. But addressing the point that you said, how would the vaccine manufacturers be able to then look at vaccines for this mutant. So parallelly, there will be a continuous effort to develop the assays through which we could run our diagnostic kits, through which we could make them available to our vaccine manufacturers to keep testing it on these. So that's a parallel initiative. Again, the planning has already gone in for it, and I think we've already started that exercise to take on. So I'll stop here, Mr. Shah, and pleasure to be with you all and share this information with you. Thank you.
Thank you, Renuji. This confidence that you are exuding about the development stage of the vaccines, it would be so wonderful to see that same level of confidence further down the supply chain, which is where, of course, the rubber will hit the road in terms of what the citizenry of our country is going to feel, the trust that they will have in the system, the problem of duds, the problem of all the other things that Ajay pointed to. So I hope you can impress upon your counterpart, Rajesh Bhushan, in the Ministry of Health and Family Welfare, and Hindu and others, that what you have done, the openness with which you have created this ecosystem, should really continue into the supply chain down the line. And some of the kind of very open approaches to distribution and delivery should also be what we see in the final stages. And I'm sure that you're working on it as well. But thank you so much. This was very, very useful. I now want to turn to, and I know that you have to leave, so if whenever you want to sign off, please do. We will catch you at a later stage again for this conversation. I want to turn to Srinath Reddy, who is eminent in the field, president of the Public Health Foundation of India, one of our wisest commentators on both public health, the financing of it, and what it means in a country with incredible capacities in one area, but perhaps gaps in other areas. Srinath.
Thank you very much. This is a virus that has thrown us many conundrums over the year, and I don't think we have the answers to several of them yet. And that's also fairly clear from the discussion that's come so far. It's been remarkably rich, with an excellent insight into how the vaccines have been developed and how they could possibly be utilized, but with a tantalizing question posed: do we need them at all if herd immunity is developing? On one hand, we are hearing that herd immunity is almost there, and if it is not almost there, it's going to be there by middle of January. On the other hand, we are asking, how are the vaccines going to be distributed? How is the private sector going to utilize it? How are the employees going to be given vaccines by their employers in the public sector, in the private sector, in the PSUs, and so on and so forth? So the question here is, are we really confident about herd immunity? In which case, the vaccines become very redundant. But if we are not, then we have to really re-examine whether we do need the vaccines or not, and what is the concept of herd immunity that we have actually started exploring at this point in time. Well, firstly, I do not believe that we have data to show that all of India or most of India has crossed that threshold of herd immunity. We do have geographically and spatially distanced antibody surveys from different places giving different estimates. But what we must recognize is that there is a difference between herd immunity and herd protection. If a particular group in a population, even if it is part of a city or a full city, crosses that threshold, it could be 50%, it could be 60%, it could be 80%, then because those who are infected or immunized and therefore immune block the circulation of the virus and protect the remaining 40% or 30% or 20%. But if any of those 30% or 40% or 20% step out into another place where the threshold has not been crossed, where the infectivity has only been 20% or 30%, they still are vulnerable to the infection. So unless you have a very static community locked in itself, with no outsider coming in and meeting one-on-one with any of the unimmunized, uninfected persons, or any of these people traveling outside, we are unlikely to see that herd immunity extend to people who are not otherwise immunologically protected either by a natural infection or by a vaccine.
And
And
that's
we
very
do
much
not,
the Dharavi issue, right?
okay.
It's a closed community.
It's a close community. Yes. And if, for example, okay, now that you've raised Dharavi, I'm fully in agreement with that. But you look at San Quentin prison in San Francisco. By end of August, more than half of them had clinical infection, not antibodies, clinical infection. And yet, California is now ravaged. San Francisco is ravaged. There's been no guarantee that just because a closed, protected population has shown a high level of infectivity, the rest of the country or the rest of the city is protected. We do recognize herd immunity does occur, but has it already occurred in India? Has it already occurred in all of India? What happens if somebody else from outside comes in and then brings in the virus? So these are the questions that we need to ask of ourselves before we declare that herd immunity has come, because there are dangerous implications. The moment you say that we have reached herd immunity, we are telling people you can stop wearing masks, you can stop physical distancing, you can start gathering in large crowds, start celebrating, and then you don't need vaccines. So are we ready to cross that threshold? I don't think so. I think our data are rather weak at this point in time. I do completely agree with Dr. Ajay Shah that we do need more antibody surveys. We need more frequent and representative surveys, but we do need all that data to actually cross the threshold. Otherwise, we will be sending the signals in the wrong direction to the people. Now, let me also mention that R naught is not necessarily a very useful thing in this particular instance. R naught is useful if you're talking about people who are infected and clinically are detectable, and therefore you can correlate how one person who is infected has infected more people. Here we are seeing a large number of asymptomatic people. We don't even know how many people one person is infected. And we also know that the United Kingdom and Germany opened up after their R naught came down. Now see what is happening in United Kingdom and what's happening even in Germany for that matter. Therefore, death toll, daily death counts coming down is certainly something that I would go more by, even if there is a bit of a noise. The noise to signal ratio is more predictable. I do see many signs that we are actually moving in that direction, but I do not think we have crossed the threshold. And unless we have that evidence, I don't think we can give a public health signal that vaccines are not needed, masks are not needed, or physical distancing is not needed, because we have already obtained the magic cloak of herd immunity around us. Now, why do we still need vaccines? Because vaccines are not essentially meant, these vaccines, which are given by intramuscular injection, are systemic vaccines. They are not meant to actually prevent the infection per se. They only prevent the infection from developing into disease by fighting the virus once it has come in. And we also know that people who are naturally infected may have a very variable dose of viral exposure. Dr. Hindu Bhushan said his antibodies came down in 1 month. We do not know what the level of his viral exposure was. On the other hand, vaccines give you a predictable, measured, standardized dose of viral exposure. So the amount of immune response is much more predictable. And therefore, a person for personal immunity would still require a vaccine, even if the population has reached the verge of herd immunity. Therefore, for several reasons, we still have to deal with the vaccines. I don't think we can say that the vaccines are no longer essential for us. Now, in terms of why some states are doing better, Dr. Hindu Bhushan raised this very interesting question that the poorer states are doing better. That is not a unique phenomenon. Whole of South Asia is doing better. In fact, some of our neighbors are doing better than us. Africa is doing well. For some reasons, this has an inverse relationship with development, urbanization, crowding, and where people commute much more in an urban environment, you're going to see more transmission. Also, you see lesser comorbidities like chronic diseases, hypertension, and so on, if you have a lesser degree of development, but that's a different issue. So we still have to be very careful about the whole of the country, but it's not entirely unbelievable. So let me try and conclude in a minute or two about who will pay. We started off by saying that UK has started and US has started their immunization program. And they are paying for it. The governments are paying for it. Now the question is, why are we saying we should not pay for it? Particularly if it is a public good. Now you may say you may not want to pay for the entire population, but at least the prioritized groups must get it. And the prioritized groups are easily identifiable. Firstly, those who are vulnerable because they might get a very severe infection or die. That is the elderly and people with comorbidities. They do need to be protected, and it is a public good in that sense because they can also infect others. Secondly, the essential workers, because the functioning of society depends on them, the health workers and other essential workers, and even the school teachers. So we do need to ensure that they get it. So if we believe that it's a public good, then public financing has to go into it. And there are so many distinguished economists in this group who can easily look at where the government has been spending and the announcements that have been made about public spending and see how that money can actually be utilized better for an immunization program. But certainly, I'm not saying that everybody in the country should be entirely done by that. And if we do actually bring down the pandemic before that, we may not need to immunize everybody. So what we really need to do is to maintain the public health precautions, not say that we have crossed the herd immunity threshold and everything is hunky-dory, then also immunize the vulnerable and essential workers, the vulnerable sections of the population, conduct good representative antibody surveys across the country and do it more frequently, on a monthly basis, gauge what level we have reached of protection, and then also look at the international situation. And then there's people who are likely to be traveling outside or receiving travelers coming in, may need personal protection for immunity, but we may have to review it in stages. But at this point in time, vaccines would be needed, at least for some sections of the people. How many people, we'll have to decide after review later on, and then see as the global situation develops, as the Indian situation gets reassessed. But I believe raising the flag of herd immunity at this point in time would be rather premature and counterproductive. Thank you.
Thank you, Srinath. So we have a counterpoint to what Ajay has put forward, and it's really important to have these two views, and I'm sure the truth will lie somewhere in between. But I wish Renu was still here, because I'd like to have very much taken your message and Ajay's message, much in the same way as that she and her department have created the biotechnology ecosphere. We need a social science or a researcher ecosphere where data are made available to researchers like Ajay and others, so that we actually have the processing of that information. The data will exist, but if it's not made available, and Indu, you could play a role here in ensuring that researchers, genuine researchers, do have access to real-time data, so that we are able to actually shed light in serious, analytical, rigorous ways on what's going on. And that's going to be very important. Let me turn now to former Secretary, Ministry of Health and Family Welfare, Keshav Desiraju, who was very much at the heart of previous such major campaigns, and now can bring both an insider and an outsider view to this. Keshav?
Well, thank you, Dr. Shah. Thank you very much for asking me, and I'm very grateful to all my colleagues we've had some very rich presentations this afternoon. There's a lot to think about, and I'll try and be very quick. The first thing is an issue that Dr. Hindu Bhushan raised, the first of his questions of should government be financing this, and he actually used the phrase, what is the rationale for government financing? And I'm glad that Dr. Srinath Reddy also weighed in on this matter. I'm actually a little concerned that this question is being asked. I mean, it is nobody's case that 100% of the expenditure should be borne by government. Dr. Ajay Shah made the point that there are any number of people who can afford private treatment and should go ahead and get it. We should encourage them to do so if they can. But I I don't believe this is a question we should be asking. And I mean, even if I'm in a very small minority, I really would like to go out on this saying that no, there is this is a public good. Dr. Hindu Bhushan used the word private good also. I don't think this is the discussion we should be having at
Keshav,
this
may I request you
stage
to maybe turn
when
off?
our public health system.
Keshav, your audio is Keshav, your audio is getting muted. Keshav, you might want to turn off your video, so you may have a bandwidth issue.
Okay, let me try and shout.
Can you turn
I
off your
was
video
saying
and then?
Oh, but I was only trying to say that I don't think this is the question we should be asking now when primary health is in a shambles in more than half the country. That we should not be asking whether there is a case for government. Mr. Sulaiman speaks to us from Madhya Pradesh. He will tell us something about exactly what governments are planning right now. And I think the very big question that this whole COVID vaccine question raises is, I believe that the question of should government pay has been answered, but how is this to be shared? Is it to be shared with state governments? If so, on what ratio? And how long will this go on? What are the central budget? What are the kinds of numbers that we are expecting? Because people have done the math as to what this is going to cost over what time period. So what is the kind of number we should be looking for in the central budget when it is presented? And what are the kinds of numbers we should be looking for in the central budget when it is presented? And what are the kinds of comparable amounts that we should be looking for in state budgets as well? And no one is talking about this, but this is, I think, a very important area that needs a lot of attention. In the course of his presentation, Dr. Ajay Shah talked about the fact that public sector capabilities are not what they used to be. In fact, he spoke about smallpox and said that in the days when India's in the 70s, public sector capabilities were much stronger than they are now. That is indeed true, right? But this is linked to the first point of the fact that we have not funded the growth of these capabilities enough. If we are today saying that what we were able to do 50 years ago in the early 70s in terms of basic public health activity, and we are not able to do it now, something has gone wrong in the way in which we have approached health sector investments over all these years. And I think that is it's worth thinking about. Now, Dr. Ajay Shah in his presentation also made the observation that the bulk of healthcare is in the private sector now. I think this statement needs a lot of clarification. I don't believe that the bulk of primary healthcare is in the private sector. This may be true of tertiary care, and I think that differentiation must be made. Yes, there is substantial private sector involvement in healthcare delivery, but where, in which geographies, in which physical geographies, and in which level of healthcare? Because I think that makes a difference. Because if we bulk of healthcare is anyway in the private sector, it's just one very small step for government to then say, well, fine, let the private sector continue to do it. But where is the public sector more dominant? Where is the public sector still largely prevalent? Then there was this point about Dr. Ajay Shah had a very interesting and important set of four, where do we go from here? I was very interested in this suggestion that the responsibility should be outsourced, and he suggested to employers. It wasn't clear to me from his presentation whether he was talking about private sector employers also, because those were not mentioned in the examples he gave, nor did he mention the army or the railways, which are our biggest public sector employees. And was that deliberate, or is there a reason, or will they be included? I think some clarification on that would be nice. Then there was a very important suggestion, Professor Shah, that you raised in response to Dr. Renu Swaru's presentation. That you asked, why is it that when everything you say carries so much conviction and confidence, why is it that there is so little trust in what people lower down the system are saying and doing? But that's a very important situation we are facing right now, a lack of trust at the operational levels. And again, since we are speaking, uh, I do believe DCGI needs to substantially upgrade its image and the levels of confidence that it inspires in people who know this business. Whereas there is actually one question that has still not been answered. Is there a date, even Dr. Swaroop didn't get to this, is there a date on which we say that the DCG is more assurance that the DCG doing
Keshav, just repeat.
is not subject.
Keshav,
This point needs to be made more clear.
Just repeat what you just said.
I'm sorry.
We couldn't.
I was
Just repeat what you just said because that was an important question.
I will repeat myself. I was actually, let me put the video on. It's difficult just to. I was saying that you made the important point in response to Dr. Renu Swaroop that the kind of confidence that she conveys, the kind of authority she commands, is not noticed lower down the line. And I was further saying that DCGI is a particularly good example of this, with an organization which at this point of time is crucial and which does not carry the authority or the general public confidence or respect that it ought to do. And many people, and not just lay people, are possibly a little concerned that the DCGI may take decisions under pressure. Now, somewhere the system, the government system, needs to respond to this. Again, the point that Ajay Shah made, that look, information needs to be made available. Who are these guys? Where is this vaccine coming from? What are the tests that have been done? And I think there is something lacking on all those fronts. So these were just a few points I wanted to make, and thank you for allowing me to speak. Thank you.
Thank you, Keshav. And thank you for raising this point about the trust that the entire supply chain has to generate in the public for it to have confidence in and overcome vaccine hesitancy and a whole range of other things that are going to be extremely important. I'm going to turn to Mohammed Suleiman, Additional Chief Secretary, Madhya Pradesh. But before I do that, I just want to share with you, this is the COVID-19 vaccines operational guidelines that are available. The URL was shared by an anonymous, so I assume that it's in the public domain. And this is a fairly comprehensive document. Suleiman, you must have obviously received it, and I'm sure that you are working on it as well. I just thought I'd share this with you. But Mohammed Suleiman, please.
Thank you, sir. Actually, rightly so, these guidelines are now available for quite some time, and they are in public domain. Everybody in Madhya Pradesh knows about them, and that's what we are working on. I could hear about the lack of trust in the place where the delivery has to come from, and I get the hint that it's primarily the state that we have to respond to it. I would just start with the basic objective of the vaccination, as we see in the state, is achieve this concept of herd immunity, and there is this related issue of seroprevalence. Just for everybody's benefit, I got the seroprevalence done in cities, 3 of them at different point of time, in Indore, Ujjain, and Bhopal, trying to understand what kind of seroprevalence is there. My highest was around 27% in Bhopal. That was sometimes in October. In November, we got an indirect method of seroprevalence done, in which the blood bank in Indore started testing everybody who was coming to donate blood. And with a small sample size, we realized that now the seroprevalence is around 40% in Indore. I believe it's a similar number in Bhopal also, that we have reached around 40% seroprevalence. But my word of caution is that this is primarily for the urban areas. It has nothing to do with the spread of disease in the rural areas. And I would want to address what Hindu Bhushan sir was saying, that the state which doesn't have that kind of a healthy system seems to be doing well. Well, if I look at the state as a whole, I mean, one critical parameter that I would want to draw your attention to is the positivity rate of the RT-PCR tests that various states have been doing. In Madhya Pradesh, whatever testing we have done, my positivity rate continues around 5.2%, just around what WHO recommends. But again, there is huge variation between the cities and rural areas, and also in the different part of the state. The Western Madhya Pradesh seem to have a high positivity rate. The Eastern Madhya Pradesh doesn't so. The district like Mandlas and Dindoris, which are primarily tribal population, they don't even have a positivity rate of 1%. So I would believe that seroprevalence varies very widely in the state. It is more focused in urban areas, not so in definitely not so in rural areas, and also within the areas of the state, it's higher in the western Madhya Pradesh and lower in terms of the eastern Madhya Pradesh. With that concept, we started looking at the vaccination because there seemed to be great urgency to roll out the vaccination as soon as we can. I don't know how the thinkings in different centers would be, but in Madhya Pradesh, I can very safely say that everybody is really, really looking forward to the vaccination. And, I keep getting lots of inquiries, when are we actually going to start the vaccination? We are in partnership with Government of India, have been working on the strategy to roll out the vaccination as soon as we can. I would just touch upon that, are we really prepared to roll out the vaccination? Having said that, I still don't know which vaccine I'm going to get, and I'm still not very sure when I would. I have fairly a rough idea that sometimes in the last week of January, we need to roll out the vaccination, especially for the healthcare workers, and that might take a little time for rest of the population. But having said that, I would say we started working on our strategy to roll out this vaccination effort. I don't know. I mean, people do doubt the capacity of the state to deliver things in a mission mode. Frankly, we have never failed in conducting elections. Every time we are asked to do, we do conduct election and ensure that everybody who wants to vote gets to vote if he wants to. So the capacity of the state to deliver in times of emergency, I don't think it can be questioned. It has the capacity. As I look at Madhya Pradesh, I'm fairly confident that even if I have to cover 100% of population for vaccination, I can do it in 6 months time flat, and absolutely no gaps in that. As I understand from the guidelines issued by the Government of India, right now what we are looking is about 30% of the population that we need to vaccinate. We are targeting healthcare workers, we are targeting frontline workers, we are targeting a population which is more than 50 years of age, less than 50 years with comorbid. If I put those numbers together, about 30% of my population would have to be taken care of. And the way I look at my system, I'm absolutely confident I can do it in about 2 months' time without compromising with the routine immunization. The Government of India's guidelines are absolutely transparent and clear that whatever effort we make for COVID vaccination, our normal vaccination will not be compromised. We have to continue with that. I looked purely from the point of view of preparedness. I look whether I have the sufficient cold chain capacity in terms of walk-in coolers, walk-in freezers, this and that. I looked at the consumables that I would be needing, the human resource. I need around 11,000 people to do it in terms of the HR requirements. I also looked in terms of the domain knowledge. We did a MR campaign which covered almost 40% of the population and do it in about 2 months' time. So from all those perspectives, I don't see a gap in terms of the planning of the state. The cost of vaccine is a interesting question, actually. In fact, we debated this in Madhya Pradesh. I don't know. I mean, as I understand, all the vaccination cost traditionally has always been taken care of by government, whether it's state or central is beside the matter. The government has been vaccinating, but there is definitely some need for vaccination of those who can pay. That we ask them to go to the private sector and buy their vaccines and get it done. Fortunately for us, Mr. Hindu Bhushan has come up with an outstanding platform, CoWIN platform, which is the one that we will be using. We have tried it out when we were doing registration of healthcare workers. It looks pretty nice and pretty strong to us.
Levan, just
there are some challenges.
Levanji, because Shekhar also mentioned that that is a UNDP platform. What we are doing is only integrating that with the National Digital Health Mission, Health ID. So we don't want to take any credit for that. CoWIN is the UNDP, Government of India, Ministry of Health platform. We are just I don't want to give a wrong message. Sorry. So sorry to.
I know, sir, but it's good to have some credit there. But that's fine. Okay. So what are the challenges that we face when we look at the COVID vaccination? There are basically the challenges in terms of what we have been doing so far and what we are supposed to do. In terms of the target group that we have in mind. So far, traditionally, we have been vaccinating infants. 90% of more than 90% of vaccination is basically less than 1 year of age. And this time we are supposed to vaccinate adults. So it's an absolutely a different ball game. And when I say these, we look at these challenges, that means these are the thoughts for which we are planning now. And I sincerely believe if you identify a problem, I am sure we can find out a solution. So we have identified this one of the basic challenge, that's a different population that we are targeting. In terms of our IEC campaign to start a vaccination, there are two things that comes to mind, and there are the questions that are being asked at the state level. The first is about the type of vaccine. Is it safe? Does it have any complication? And second and more important question is how long will it last? In our earlier vaccinations, we knew exactly how long will it last, but for this vaccine, we don't really know how long this vaccine is going to last. In terms of prioritizing our target group, uh, as I said, it's basically frontline workers and healthcare workers and more than 50 years of population. There is this antibody, the question of antibody. The guys who have already developed antibody, should they be vaccinated? ICMR has deliberated upon this point number of times. My own colleagues in different governments raised this issue with government of India, that should we take out the guys who already developed antibodies and do not vaccinate them. There are two challenges in this. First is the practical problem. That means I have to first test everybody for antibody and then go for vaccination. Much more time consuming, much more expensive. Second, we don't really know how long the antibody is going to last in an individual. In fact, I'm going to report to ICMR in a few days' time a guy who is reporting third time positive in 4 months' time. So I don't really know what kind of things are happening. So there is this question of antibody, and that's why ICMR finally seemed to have concluded that we don't have to go for antibody tests. We have to vaccinate whosoever we wants to do. There are issues in terms of session planning. That I would be addressing the challenges. Our normal vaccination is we will go door to door looking for guys and try and take them out from their homes and vaccinate them, whether it's for polio or for routine immunization. Now in this drive, there's another concept we are thinking, that we have to follow the election mode. That means I want my team to go and sit at a proper place, and I want people to come there and then get themselves tested get them vaccinated, and then go home. That would actually mean that I need to pre-register everybody whom I saw or wants to be vaccinated, give him a proper time schedule, ask him to come back there, and then only I vaccinate him. There are also security considerations. People believe that there might be the vaccination team might face some security challenges also when they go to the villages. So it's a new kind of approach that we will have to follow, and that we are already planning for. How do we do our session planning? This also has a implication for a security for IT structure. I started hearing rumors about people asking for OTPs and trying to link it to some kind of wrong activities. So there is a technological challenge also, and IT security considerations also come into. There is also an issue of wastage reduction. The vial of vaccine has 10 doses. I need to carefully plan my sessions, that if my team is sitting in a village, it should not get only 2%, and then it cannot waste 8 of them. So I need to have those kind of consideration in mind when I do my session planning. One of the critical activities that we are carefully looking at is how do we manage the adverse event following immunization. We need to put a system in place that the public opinion is not affected because of individual events. I'm sure all of you would have heard this news about Honorable Minister of Haryana getting his first dose and getting infected, created so much of public opinion on the entire thing. So that thing also, how do we manage the WhatsApp news channel that we keep sharing all the times? How do we counter the rumors? These are the challenges that we are going to face. But I would just would like to conclude it by saying that the success of any initiative at the state level comes from the political will behind that initiative. Right now, there is a great public demand and the great public political support for this vaccination drive, and I don't think any state, would be found wanting in that. Thank you, sir.
Thank you, Suleiman, for that ground-up view, and really the kind of details that you need to go into. The notion of wastage is going to be terribly important, given how precious each vial of the vaccine is going to be. So It's actually, this gets to a little bit of Keshav's point about, can we have confidence throughout the supply chain? And I think you are bringing to that, your comments were responding, I think, partly to that as well. Let's turn to the international arena and think a little bit about what multilateral agencies and foundations like the Gates Foundation are doing, and what their sense is in terms of what India should do, both to be a good world citizen in its role in being able to use its voice with its 1.3 billion people in order to bring about an equitable distribution, but also in terms of the support that multilaterals as well as the foundations of the world can give to this very large country. Junaid Ahmed?
Thank you very much, Shekhar. As a member of a multilateral institution, today I sit in a very uncomfortable position because what do we have to report on? We have to report on the US getting vaccinated, the UK getting vaccinated, China is vaccinating, and some of the Latin American middle-income countries are vaccinating. That I am not bringing to you the story of X number of African countries and Y number of South Asian countries getting vaccinated. Now, having said that, I recognize that we are months into the vaccination story after a historic development of a vaccine. Having said that, I think for us, there is a lesson already that when the sequel comes, because there will be a sequel, we must not be in a position where the North is the one that's getting the vaccines first and the South is having to wait. I think to me, this is a very important lesson. You look at South Africa. South Africa is a producer of vaccines. It is producing vaccines that are all going to be exported, but it is a country that is both the middle income and inequitable, that it does not have access to vaccinating its population. So there is an inequity issue at a multilateral level that we do need to rethink, that we need to be prepared for. And I'm hoping that the COVAX story, at least, is one that's going to show us the equalization in terms of access. In terms of the World Bank, we entered the COVID game immediately with a major program on public health. As the public health unfolded, in fact, in the case of India, after the Honorable Prime Minister announced the first program on public health, within 15 days, we had $1 billion program in India. That has never been seen in the bank. For the vaccine part, we've created an equal level of support to countries should they want to get access to the resources. These are resources that countries are borrowing in order to spend. So there is a World Bank program, global program, both on the public health as well as on the vaccine that's available. India has really leveraged the World Bank on the public health side and less on the vaccine side. Although Renuji mentioned that we've been working with the government of India on the building of the ecosystem of innovation, which has led to some very interesting storyline that was prior to the arrival of COVID. Let me maybe talk to the question that's been put up brilliantly by Ajay. I think you have in the story here two very different storylines. One is the machinery of the state for vertical programs, emergency, top-down programs that India is well known for, versus Ajay's story that in such variety and diversity, you really want multiple approaches, you want decentralized approaches, you want to leverage markets. I would fall in the second school of thought if you ask me. But the reality of India is not a reality where Indian planning and policy making is one that relies on that second role of delivery, be it water, be it electricity, or be it vaccine. So I think the debate is not whether it should be one or the other. I think the debate is really that we have to piggyback on the state system, which indeed I agree that the state system in a mission mode is quite formidable if, and this is where I think I would add, if the decision-making is given to the state level. This is where I believe that the power of India lies, is in its federalism, and that you allow and really piggyback on the diversity of the states and state capacity to move forward, with the center playing a very important role, that those states that don't have the capacity to really come in with a surge and really create cross learning amongst the state. I think if you create that kind of leveraging on federalism, you will get a hybrid of what Ajay is saying and what I think we are hearing from our other colleagues, that this mission mode is a very strong delivery system. So that's my first point. My second point is, I think we have to, given the uncertainty that we have about herd immunity, the uncertainty we have about the impact of the vaccines, uncertainty about how long immunity lasts, we have to go with the no regrets strategy. And my sense of the no regrets strategy is to look at vaccine not as a silver bullet, but part of a broader program. And that as you enter into vaccine, you have to, one, absolutely emphasize, as Srinathji said, on the public health story, that cannot be forgotten. And in fact, this is an emergency that should help us strengthen the public health system of prevention, of the type of delivery we see at the third tier. And here, improving urban public health, I think, is a very, very important aspect of that no regret solution. Second is, I would put quite a bit of effort in the therapeutics and the whole story of repurposing drugs. One of the stories I'm seeing in Bangladesh, and I think, and I would bet, related to Bihar and related to UP, is the use of ivermectin as a therapeutic to deal with what we're seeing. There's a lot of work that needs to be done, which is not being supported by regulatory agencies around the world. They're all busy trying to figure out which vaccine works, but very little effort is being put into looking at therapeutics and repurposed drugs. I think that's another area that needs to be looked at. Third is One Health. The sequel is coming, and the sequel will come from One Health. Today, how much has India put into One Health versus how much has India put into the other aspects? So these are, to me, the public goods side that has to be part of the vaccine strategy. And I think the fourth area would be the two areas that Ajay has mentioned. I would put quite a bit effort of public money into boosting the supply side. We ought to create that price collapse, though I won't use the word price collapse. You ought to create the supply to drive the price down, because only by driving the price down can you open up services into the private sector, people going to the private sector. In other words, you can't be enabling a delivery of 1,000 flowers with a ration supply. That's going to be very, very difficult to do. So you want the prices to fall so that there is it's driven by supply side. And finally, the testing. And the testing is part of the whole data system. If the data system is not available, you're not really going to be part of delivery of this no regret strategy. If we look at what has happened in the COVID first 12 months, remember we started in India with a panic. Where are we going to get the PPEs? Where are we going to get masks? Where are we going to get ventilators? And today, in all of these sectors, India is an exporter. Prices fell tremendously. There was a real capacity story that emerged. And it emerged from central government involvement by drawing in small, medium entrepreneurs in the delivery of these medical stories. So I think that there is a real story here of the central government, state coming in, the center coming in, but in partnership with the state to unleash this kind of capacity that exists within the country. I think here leveraging federalism, leveraging the private sector, and leveraging communities, I think becomes very, very, very important. The whole Anganwadi, the self-help groups, this is a front line that is extremely powerful in the public health story and can be powerful in the vaccine delivery story. So I sort of look at India as the place where we're going to learn from many parts of the world. 1.3 billion in a nation which has 29 countries in effect. The lessons you learn here are the lessons you take outside. The very little lessons that you can bring out from outside to easily fit in. And I think the answer to today's debate is somewhere between the mission mode and the decentralized mode have to meet. And my sense is that meeting place happens at the state level, and therefore leveraging the state capacity and supporting those states that don't have the capacity is probably going to be a very big part of the vaccine story.
Thank you, Junaid. And that's clearly a challenge to Suleiman to not just do stuff in Madhya Pradesh, but then what's the forum where states will be able to learn from each other? And Hindu, that's also in a sense a challenge for you, since you are pan-national and cover the whole country. Let's turn to Harish Iyer from the Gates Foundation, which has been at the core of the thinking on vaccines, I guess always assuming that there's going to be a pandemic, and the kind of incredible foresight that Bill Gates has shown has clearly stood the world in great support and great need. So, Harish.
Thank you so much for inviting me to this absolutely amazing panel and all the very interesting discussions. So I'll try and avoid talking about some of the same things again, because I agree with many of the comments that were made. I think the foundation itself has been on the forefront of the biomedical R&D, if you will, and funding institutions to try and understand whether it's being participating in the solidarity trial for therapeutics, or the vaccine work, or the antibody work. So a lot of the thinking around the foundation is how do we make sure these interventions are accessible to people at the bottom of the pyramid. And in sort of pursuing that, we worked closely with Gavi to make sure that there is bridge financing given in large amounts to make sure that people take the risk and manufacture large quantities of the vaccine, share the risk, let's say, to make sure that a well-validated vaccine, a reasonably well-validated, I mean, obviously this is a very emergency time, a reasonably well-validated vaccine, with a reasonable set of data is available to the LMICs. So the discussion around collaboration is kind of interesting, right? I mean, I think there are areas where the rich have done whatever they wanted. Clearly, the rich countries have done whatever they wanted. They've not, but there are also areas where rich country institutions have collaborated, right? So it's a mixed, I would say it's sort of a mixed bag. So certainly, if you take the serum vaccine, for which we did, through Gavi, supported Gavi to make a $300 million investment, we know that that's enabled Serum to start manufacturing vaccines ahead of time. It was a Oxford vaccine with a lot of global data, and hopefully, if it does get approved, it will be available. It's the cheapest vaccine available in the world today, with a ceiling price of $3 per dose. I think Ajay is absolutely right that the prices will likely crash. If everybody makes 1 billion doses and there may not be as much of a demand, prices are probably going to go down. So it's also a bit of a dangerous situation for companies that have put out lots of money, and we need to make sure that they're viable. For India, the question will be, where will it purchase vaccines from? Will it purchase it? How much will it purchase through COVAX, the COVAX facility, which has been funded by many, many, many people? We hear that a significant portion of the COVAX amount guaranteed may come to India. So if India needs 600 million doses, as people are talking about, how much of it will come from COVAX? How much of it will India pay for directly? The numbers that I have seen in terms of the financing needed to do this, if the government has to pay for it, are significant, $1.5 to $2 billion. I think Mr. Bhushan also talked about it. 7,000, maybe more than 7,000 crores possibly. A significant amount of money. How do we accomplish that? Should rich people pay for such vaccines themselves, but not be jumping the line. I mean, the jumping the line is the most critical aspect of all this. I think the presentation of the vaccine today, and I want to, because I'm a technical person in vaccine development, I will talk a little bit about the presentation of the vaccine. The vaccine is in a 10-dose format. It's much more cost effective. And you use lesser amount of glass. You could arguably say that you have to calculate the wastage of such a vaccine, but it's ideal for mass use. When you go into private markets, it's often a single dose vaccine, which is used up a lot of glass. So if 10% of the country needs a private shot, you may run out of glass and auto disable injectors, and there are lots of supply chain issues that kind of play along. So one could argue rich people should pay for the vaccine, but they should still stand in line, in exactly the same line that everybody else would stand in, right? They're exactly the same spot they're supposed. That would be a more equitable approach. It would be a less, in my mind, this is a personal view, of course, that's probably the right way to do it. A couple of other areas where, of course, the foundation has been trying to support the government of India. One is on communication support. We certainly believe that across the world, AEFIs or adverse events following immunizations are likely to come up. And, the US, for example, for the Moderna vaccine, actually stopped the trial for a month, saying, share all the data because of one or two events. Can you imagine if that happened in India? What would we do? Would our investigatory system be able to handle it? And we are early in the game of using this vaccine. So obviously we won't know everything about it. There's some experience everybody has, but once you roll it out to millions of people, it's something that, would have to be thought about. How do we communicate on it? How do people gain trust at the highest levels? Senior people in government who are highly trusted by the population should, take the vaccine. Perhaps we saw this happening in the US. So the confidence building campaign will be super, super important, I believe. And then, of course, the other question is animated. Lots of discussions, at least at the foundation and people, that we talk to, is obviously the liability question. What is the reasonable liability cover? How do you deal with that kind of an issue? What is the US doing? For example, I think they have a different no-fault compensation system that they're trying to do. What is the UK doing? And assuming that the Oxford vaccine will be the first one that gets approved, I don't know if that will be the case or not. They certainly seem to be the most advanced for India. How does the UK do it? And how does the MHRA, how the UK government do it? How will the Indian government do it? These will be interesting questions to understand. Of course, much of this, I believe it's appropriate that the government and expert committees from the government, drive a lot of this conversation, certainly with inputs from society, because ultimately this is a public health question. They will be responsible. They will be called into question no matter what happens if something goes wrong. So I think, obviously the Ministry of Health, for example, in my mind would be one of the leading players in making sure people are comfortable and confident that they will get taken care of well and their health will be protected. I think I will stop there and happy to answer questions if anything specific comes up. I also wanted to add on the One Health topic. It's a very, very important topic, where we have a coordinated approach. Many viruses jump from animals into humans. We know that it's the case for HIV, Ebola, and it's not likely that that's going to go away anytime soon. So good to have using this opportunity to really expand on public health, expand the knowledge we've gained from R&D and the regulators on how can we speed up many other diseases which are not as prominent, which also don't show up in the spotlight, which cause an enormous health burden on the country. How can we make sure that those are also addressed in this kind of fashion, right? We have, TB, malaria, and other diseases of equal importance. So over now. Thank you.
Thank you, Harish. We are at the end of our scheduled time. With your permission and with the understanding of our attendees, we have about 60 or more. I would have very much liked to have called on Gagandeep Kang, who was with us, but she had to leave by 8. Let me see if I can get Chandrakant Laheria, her co-author on this book that I'm sure you all have either purchased or should purchase, Gagandeep Kang, Randeep Guleria, and Dr. Laheria have written this very accessible book, which is very contemporaneous. It's almost, it doesn't yet have the Pfizer vaccine already being administered, but it certainly does give you one of the best views on where we are. I wanted to ask, with your permission, maybe extend this by 15 minutes, but ask Srinath, what are going to be the larger consequences of this intense attention to public health that India has never had before in its 70-odd years? Nothing has moved the needle in quite the way that there is the possibility of doing now. And can we see the silver linings on the cloud and to say that this is going to transform public health in India? And what should we be doing? What should Hindu be doing? What should Suleiman be doing? What should the World Bank be doing? And others who are interested in this area, so that we can actually not just get over this hump, but prepare ourselves for many more humps in the future.
Well, firstly, I think there has been a great deal of attention. Usually in past, whenever there's been a public health emergency of any kind, it lasted for a short while, and then the attention disappeared, faded away from the newspaper headlines as well as policymaker minds. Now, whether we like it or not, COVID has been there for a year and we're likely to be around for some more time. So I think that attention on public health will continue, but we need to channel it into the right solutions. We do definitely need to strengthen our health system performance by building up more capacity in primary healthcare, district hospitals, and medical college hospitals. Of course, the entire laboratory complex also across the chain must also be strengthened, but without an adequate health workforce, if you look at primary healthcare, the initial case finding with household syndromic surveillance of early reporting for testing, contact tracing, and even now looking after the post-COVID long-term effects of people who have had COVID and now are still suffering the consequences, or even the whole area of immunization, all of that is fundamentally dependent on primary health care. And we saw even in severe cases, oxygen in district hospitals was probably more helpful than ventilators in advanced care. So we need to prioritize different limbs of the healthcare system and connect them very well. Lack of connectivity between the various levels of healthcare has been a problem as well. And of course, we do need a multi-skilled, multi-level health workforce to be expanded, and a lot of citizen engagement, as has been stated already by Junaid, that it's absolutely important that we need to get that into play. But much of this is not going to happen, whether it's laboratory complex or primary healthcare or health workforce or health information systems with technology. All of that's not going to happen without adequate public investment, both at the central and state level. And that is something that we must really ensure happens and not just become an aspirational element.
And I guess I would add political leadership,
Of course.
which very much is going to be driven by what senior civil servants like Indu or Suleiman are going to tell the political masters. And I hope that you will convey this message, that for once we have the opportunity to break through in some sense. Ajay, you've been listening very quietly, and I'm sure imbibing all these things and analyzing them. From what you've heard, how can the research community, which is where you and I sit, really empower our civil servants and our politicians to do the right things?
Well, our job is to think and to read and to write. And I think all of us are trying that. I think there is now an early wave of good research papers coming out about COVID-19. We need 100x more researchers and 100x more research. So I feel that there really needs to be a lot more work on these things, on questions, health, excess deaths, mortality, the seroprevalence papers. There's just so many things waiting to be done, and only we in the research community will be able to do those things. I think it's very important. And more generally, I think I can certainly speak for most of us on this panel. We bear the scars of the difficulties of public policy in many fields. We have been optimistic many times before. And so I think our biggest contribution can be a certain methodological humility that, in the bowels of Christ, consider it possible that you may be mistaken. So I think it's wise to let many flowers bloom. Many things should happen. Let many people try many things, and we never know which one will work. So, yes, we should try big, ambitious things. Yes, I would love it if the city government of Pune would do a great job of a public system in Pune. But in all probability, that might not work. And maybe there'll be lots of private firms who will just go over to Serum Institute and sell vaccines to private people. Let's not prevent that. Yes, it'll be great if the Maharashtra government will try some stuff, and maybe that will work in Pune, and so on. Who knows? Basically, we don't know what's going to work. And so we should not be so dogmatic like we've figured it out. Let's let many energies play out in the system. And Shekhar, you need to get on the phone and line up vaccination for your employees. It is your job. It is not the job of the government of India.
Yeah, I've got a private deal with Moderna, so
Call
my
Apollo
ship-
hospitals. What does it take?
my
we should go
shipment
do
is
it.
just waiting. My shipment is just waiting, and I've lined up UPS, and they're all ready to go. So Junaid, please, and then I want to turn to Suleiman on how he sees the identification of the core groups in Madhya Pradesh. I think that's going to be an important question. How are we going to identify the ones with comorbidity? Given information, given the inability to be honest about one's own physical morbidity, there are lots of questions here. But Junaid first. Junaid?
So Shekhar, I think you asked a very important question in terms of whether this shock has shifted the thinking in public policy. And from what I'm seeing, there has been a shift. And I think one of the most important shifts is what's outlined so well in the Kelkar Shah book, the distinction between public health and health service delivery. This confusion as to when it's a public good and when it's a private good, and you land up doing things which you think is a public good but is not. I really think that the needle has begun to shift towards public health in its true form. And I think there is also a recognition that the expenditure per capita on public health in India needs to go up. And I think that there is also an understanding that that shift is not about a social expenditure, but it's actually investing in the human capital and growth path of India. So there's a change, I think, in the tone of what it means to invest in public health. And I'm hoping that the state governments will step up the conversation on public health, because that's the partnership between the center and the state that I believe could lead to 1,000 flowers blooming that Ajay correctly points out to.
Thank you, Junaid. Shilpa Sharma has just shared with us a FICCI EMI paper on protecting India, public-private partnerships for vaccinating against COVID-19. Suleiman, I'm going to turn to you for almost the last word, and I've just seen that Chandrakant Laheria has been on the webinar. He's one of the authors with Gagandeep and Randeep Guleria. So I'll turn to Chandrakant at the very end. He's heard us patiently, and he's written this book, very thoughtful book, so we'll get a word from him as well. But Suleiman.
Let me say this COVID thing has been pretty good for the health sector, the public health sector in some way. I would just want to share this happy news with you that in next 3 years, we will add around 700 institutions in the health sector, including the PHC and SSCs. If I do the yearly comparison, it is 10 times more than what I was doing in the last 10 years. So the government's attention to the health sector definitely has come into it. I can share this with you that for the first 4 months, the chief minister used to have a daily VC of about COVID with all the district collectors. So there's a lot of attention now coming back to the health sector. Our allocations are going up and things are looking good. In terms of the vaccinations, you really pointed out, it's a serious challenge for us. How do we pre-register people? because this is not only just a person, it is also his geographical location. We played with election voter list and thought of picking up guys from there who are more than 50 years and then registering them. But there is lots of movement. Some of them have their name registered somewhere else, actually living in urban areas. And if you have to get them vaccinated in the place where they are working and where they are living are different, then it's a challenge. So lots of work is actually going on. This same thing applies to person with comorbid condition. But the good thing is that government of India so far has been very liberal. I mean, we would tend to err on the side of choosing a wrong person. If he claims that he is 50, we'll simply accept that he is 50. If he claims he has a comorbid condition, we are not going to test him for that. It's just that a few more people will get vaccinated than what they are supposed to do. We did the similar exercise when we registered 380,000 healthcare workers from the government and private sector. We didn't ask questions. Even if the guy was actually a computer operator in a hospital, we simply registered him as a healthcare worker. So I think we'll continue with this liberal attitude, and I think that would ease out the process.
And that actually is quite in the spirit of Ajay Shah's suggestion about how we do this. Listen, this has been a fantastic panel. I'm going to, Indu, do you have a last word on this before we turn to Chandrakant as a complete outsider to this discussion, but obviously somebody who's very much involved in this area? Indu, if you're still there.
I'm okay, Shekhar. Maybe
okay.
Let's listen to Chandrakant.
Chandrakant, I've just been extolling the virtues of your book, and you've been very patiently listening to all of this. Gagandeep had to leave, I am sorry, but do you have any guidance, advice from writing the book, from the reception the book is having, from the kinds of questions you are getting? Chandrakant?
Thank you very much, Dr. Shah. And please allow me to keep my video off if that is possible.
Sure.
So, yeah. So this had been a really fabulous discussion, and I really thank you for introducing the book. This book, we three of us have written, focuses upon how India has fared till now in the COVID-19 pandemic response. But I would say that this is a book about how to strengthen India's healthcare system. I would be focused on the discussion today. It was fabulous. So I would not add much to what had been discussed, but I would like to highlight 2 points. One, in the beginning, from the very beginning of the pandemic and in the initial few months, we were hearing a lot about health and health system strengthening. However, if we look around and notice now, the focus has entirely shifted mainly to vaccine and vaccine delivery, which is rightfully so. However, I would bring a word of caution that the attention which at all level was from the policymakers to the health experts and even journalists, and every section of society was thinking and talking about health system spending starting from March till September 2020. I somehow perceive that attention is we are losing. We should not miss that opportunity, that the attention which country received to strengthen India's healthcare system should be completely waved off or forgotten in the attention to deliver vaccines. So my first point is we need to continue to retain focus on strengthening India's healthcare system. There have been many learnings from the pandemic experience, and those should be utilized. And that's what in our book we deal with. Rather, in our book, we have an entire chapter dedicated upon that how to strengthen India's healthcare system. And we have tried to link with every phase of pandemic, before the lockdown, during the lockdown, and during the unlock period. What are the key learnings from the pandemic and pandemic response for strengthening India's healthcare system? We should retain focus on that. I'll quickly come to the second point, and that is that it's an exciting opportunity for India to deliver vaccines to adult population and a large number of people over a shorter period of time. India has some experience, though, for children on polio mass campaigns, also for measles supplementary immunization activities, where the country vaccinated around 240 million children, mostly 9 months to 15 years of age over a short period of time. So there is some of the experience. What this COVID-19 vaccination drive for adult population provide another opportunity to strengthen India's routine immunization program. We still, with the many efforts of Mission Indradhanush and intensified routine immunization program, still deliver all recommended vaccines only around 78 to 80% of children, while our neighbors do year after year for 95% of children are vaccinated. So while we pay attention on delivering COVID-19 vaccine, it should be utilized an opportunity to strengthen universal immunization program in India. And there should be some efforts to do those kind of initiatives. So I would stop here. Thank you very much for this opportunity. And please do read book Till We Win, India's Fight Against COVID-19 Pandemic. Thanks, Dr. Shekhar, for kind words and for this opportunity.
Not at all. Thank you, Dr. Laria. Very kind of you to make these very important points. It's to all of us, but Srinath in particular with the foundation you lead, and of course our civil servant friends, Mohammed Suleiman and Hindu Bhushan, and I'm hoping that Renu Swarup will also, she and I will be talking and I'll try and convey some of these views to them. I want to thank this incredible panel for the time that you've devoted. I think this is a public service you are doing. We need very much to both know how we will deal with this challenge. At the same time, we need to be conscious of what assets we have, what is working for us, and therefore how we need to develop our own approaches to both production, storage, delivery, and ultimately administration of the vaccine. You've all been great on this panel. Thank you so much. I want to just thank Srinath. I want to thank Ajay Shah for laying things out. Keshav, your experience in this area. Harish, your international perspective. And I want to thank the Gates Foundation for whatever it's done. It's clearly shown the way for many other philanthropists on what they should be doing. Hindu, your contributions, Junaid, yours as well. I thank you all, and most of all, I thank our attendees who patiently heard us. Please write in. There have been a bunch of questions which have been shared with the panel. We will come back to those if we can. Again, thanks all, and please be safe. Remember, it's the vaccine, but as Chandrakant has reminded us, let's not forget the lessons on public health. Good night, everybody. Stay safe, and hope to see you again soon.